Great, thanks so much. Thanks, Dr. Rohrbach, for being willing to host the webinar today. I just wanted to introduce Dr. Rohrbach, who is an Associate Professor of Preventive Medicine and directs the Master of Public Health program at the University of Southern California Keck School of Medicine. And her research focuses on interventions to prevent health-compromising behaviors among youth, including tobacco use, alcohol and other drug abuse, risky sexual behaviors, and violence. She has interest in translational research, including investigating factors that explain and strategies that enhance the dissemination and implementation of evidence-based programs in school and other community settings. And she received the Translational Science Award from the Society for Prevention Research in 2011 for her work in this area. So I just wanted to welcome and thank Dr. Rohrbach, and we'll hand it off to you.
Okay, thank you very much for that introduction, and hello everybody, and thank you for inviting me to talk about some of my work. So could we go to the next slide?
Yes.
This is an overview of what I'm going to talk about. I'm going to begin talking about a conceptual framework that has been behind much of the work that I've done. And then I'm going to talk about some dissemination and implementation issues in schools, and I'm going to use as an example a project called Towards No Drug Abuse that I've been involved with for the last decade or so. And then I'm going to talk also about implementation of substance abuse prevention in communities and use as an example a project that I'm working on right now with LA County. So let's go to the next slide. So I think right now the field is very much views dissemination and implementation within a systems framework, and I adapted this from some authors who wrote an article several years ago, Durlock and Dupre, but a author by the name of Wandersman has actually developed a framework that's quite similar. Some things to note here. First of all, adoption and implementation, and prior to adoption, dissemination. The idea is that it occurs within a system and a context that is fairly complex. So the context has funding, policy, climate factors. It has factors related to the community in which the work is being done, factors related to the organization and individuals that are providing the service, and all of that forms an infrastructure in which prevention programs are adopted and implemented. Now, this framework also shows that what's going to influence whether implementation occurs and whether it occurs with fidelity and is done well. There are factors related to the prevention delivery system, so that has to do with the organizational capacity of the organization doing the implementing, so the climate, the norms, leadership factors, the procedures in that setting. And it also has to do with the prevention support system, which relates to training and technical assistance that the organization and individuals receive before implementation. So let's go on to the next slide. I'm now going to move into the area of substance abuse prevention and talk about application of these concepts in this framework. So in this field, we've actually had we've had decades of research on prevention approaches, and there are quite a number of approaches that are empirically validated or that are so-called evidence-based. Most of the research has been efficacy research, so most of it has been conducted under conditions that are ideal or more ideal for the researcher, and so we know more about the efficacy of these programs than we do about the effectiveness of them. That is, effectiveness is when the research is conducted under less ideal conditions when it's conducted in real-world situations. So as a result of this body of research, the field has made available quite a few prevention programs. They're being disseminated widely, and there are quite a few guides that have been disseminated about the evidence-based programs, what they are, the research base for them, how to get a hold of them. And we have seen in the last decade quite a few policies where local communities and schools have been encouraged or in some cases mandated to use evidence-based programs only. Okay, next slide, please. So despite this backdrop of policies, funding, the availability of these programs, what we find is that there has not been widespread use of them. And I suppose this could probably be said for other areas of prevention program, that is, even though the programs are available and we encourage implementation of them, the implementation has not been so strong. So I was involved in a national study with Chris Ringwalt and colleagues a number of years ago. We did a national probability sample of schools throughout the country, and we took a look at, in middle schools, how many were using an evidence-based program. And we found only about a third in 1999. And by the way, in 1999, there was a policy passed at the federal level that schools that were receiving federal funds to do substance abuse prevention through the Safe and Drug-Free Schools funding mechanism, they were mandated to use evidence-based programs. We went back to the same schools in 2005, and we found that the prevalence of use of them only went up a little bit to still less than half of the schools reported using evidence-based or proven programs. And then we see in high schools that the prevalence of use of evidence-based programs is quite a bit less, only 10%. So let's go on to the next slide. So there's a pretty good body of research in this area about the kinds of factors that are associated with both adoption and implementation of evidence-based programs in schools. And I've been involved with some of this research, as have many other people around the country. And again, supporting the framework that I started out with, we find that a number of characteristics of the programs themselves are related to use of these programs. So those that are considered to be more attractive, more user-friendly, more easy to use, that have methods that are familiar to the school people, those are more likely to be adopted and implemented, and those that fit with the goals of the organization. At the organizational level, there's a pretty good body of research that shows that where you've got strong leadership for prevention programs, strong leadership and support, where there's ideally a so-called program champion, somebody who's saying, yes, we should do this and it's important, where there's a positive school climate and norms within the organization that recognize the importance of prevention, and so on. Those kinds of characteristics are associated with greater use. And then at the implementer level, there are some characteristics that have been shown to predict whether somebody will implement an evidence-based program when a person is more positive towards it, more comfortable with it, feels that they have the proficiency to implement it well. Those are all associated with implementation. Now, the other thing that we know from previous studies is that when people who are have been asked to implement these programs or who have volunteered to do so, when they get training and technical assistance throughout the implementation period, they're more likely to implement. So let's go on to the next slide. So overall in the field of prevention, I think these are some of the key research questions that the field is looking at and needs to look at in the future. My colleague Dick Spoth and I wrote an article a couple of years ago where we did a review of sort of the state of the art of translation of prevention programs around the country, and we identified some key research questions that we think people should be looking at in the future. Now, what I've done is shown in red here a couple of questions that are related to training that we identified as important, and these are a good segue for the study that I'm going to tell you about in a minute or two. So as I said before, we know that implementers and organizations that get trained are more likely to do evidence-based programming, and they're more likely to implement them with Fidelity, but we don't really know that much about what the effects of different modes of training are and different modes of providing technical assistance are on implementation. So we don't, right now we don't know how much training do people need, what types, and what's sort of the ideal mix. So let's go on to the next slide. In the area of school-based prevention, again, we know that from previous studies that it improves implementation. We know that technical assistance appears to be important, but most studies have just observed these relationships. They have not experimentally manipulated them. So let's go on to the next slide. So we decided to do a study in which we would study training methods that would be appropriate for dissemination of a substance abuse prevention program called Project Towards No Drug Abuse. This is a program that is taught in a school setting, and it has 12 sessions. It has been recognized by federal and state entities as being evidence-based, and the target group is high school age youth. And before we did the study that I'm going to talk about, we had done 5 NIH-funded trials on this approach. And across those trials had found that the program does result in reductions in substance use, that is use of cigarettes, alcohol, marijuana, and hard drugs among youth. So let's go on to the next slide. So in this particular study, we had 2 main questions. We were interested in comparing the relative effectiveness of an enhanced training model that would involve more components, and I'll get to what the components were in a minute, versus a standard training. I use the word standard, and this is the training that we compared it to is the kind of training that is usually given to teachers and school personnel who are going to implement substance abuse prevention programs. And then we were also interested in a broader question which gets at the effectiveness of the program, and we wondered, is the program going to be effective when it's implemented by teachers in real-world settings? So this made this trial different from the 5 previous trials. In the 5 previous trials, our research team went in and did everything. We designed the program, we went in, we implemented it, we evaluated it. In this case, it was a scaling up of the program, a scaling up and a dissemination to sites around the country, and we were interested in looking at the outcomes. Does it work under these conditions? Okay, so let's go to the next slide. So as I said, we were interested in comparing 2 training approaches. One was a standard training workshop. So this was just a one-day workshop, and as again, this is sort of usual care in the field. The next was a comprehensive implementation support training. So in addition to the standard workshop, the teachers got web-based support. They got on-site coaching, so we visited their site at least once, observed their delivery of the program, gave them some feedback, and then they had technical assistance available from us as they needed it. Now these two conditions, these two training conditions, were compared to a control condition that received the intervention several years later, but at the time they were a control that had not received any intervention. Okay, I think you need to you need to advance the next a couple of times because this slide is animated. Sorry. There we go. So if you could go on to the next slide. Thank you. Okay, so this shows you where we conducted this study. We had sites around the country. We had bigger cities. We had rural areas. And we had a total of 65 schools. Okay, next slide, please. So, and could you advance one more time? Okay, so this shows you the conceptual framework for the study. We hypothesized that the intervention would result in greater fidelity of implementation, that is faithfulness to the model, and that the training would result in, that the greater fidelity would result in stronger changes in short-term outcomes for students regarding their beliefs, their skills, their knowledge, and that these short-term changes would result in stronger, longer-term changes among the students in the form of reduced substance use. And then we hypothesized that some factors in the environment relating to the school context and to characteristics of the teachers and the would moderate and mediate the relationship between the training and the outcomes for the students. Next slide, please. So as I mentioned, one of our short-term outcomes was the fidelity of implementation. So we went in and we did observations of every teacher who participated in the study. We did almost 100 observations, and we compared the fidelity, which was a composite score. It got at how well they adhered to the model, how well they facilitated the program. Did they get interactivity? Did they establish interactivity with the students? Did they get positive reactions from the students? So it was a composite of those factors. And we did find that the fidelity among those who had received the more comprehensive training, that the fidelity was stronger. Next slide, please. We also took a look at, well, what would explain the effect of the training condition on fidelity, and we took a look at some of those contextual variables that I mentioned earlier, contextual variables related to both the teacher herself and the school context. And we did find that the relationship between the condition and fidelity was mediated by changes in the teacher's self-efficacy. So those in the more enhanced training felt stronger self-efficacy to implement the program well and did indeed do a better job of implementation. Okay, next slide, please. Okay, so we also found that those teachers who were in the comprehensive implementation condition had produced some stronger effects on short-term variables for the students, so knowledge, intentions regarding substance use, and the students who were in the classrooms where the teacher had gotten the more enhanced training had more positive reactions to the program. So there was some evidence, at least in the short-term outcomes, some evidence for the superiority of the enhanced condition. Next slide, please. However, when we looked at the long-term results, so we went in a year later and we took a look at whether there were reductions in student drug use. And if you look at the bottom part of the slide here, between the enhanced training condition and the standard training condition, we saw no differences in student drug use outcomes. We were a little surprised by that outcome. It's not what we expected. We expected that the better training would result in better fidelity and stronger short-term outcomes and stronger longer-term outcomes. So when we step back and answer the question of was the program effective when implemented in these real-world settings, we did observe a reduction in marijuana use, one of the substances that we looked at. We did not see effects on cigarette and alcohol use, and we saw effects on hard drug use only for a subset of the participants. So overall, this pattern of results showed weaker effects for the program than we had observed in all of our previous trials that were more highly controlled. That is where we went in and basically did everything in terms of implementation. Okay, next slide, please. We also found, we went back after 2 years, and we just, the only thing that we asked at that point was, are you sustaining implementation of the program? And we found at 2 years that the teachers in the two conditions, the majority of them were sustaining implementation, and there was basically no difference between the two training groups. Okay, next slide, please. So in summary, we found that the scaling up of this program around the country, when we scaled it up, implementation did produce a program effect. However, it was only on one of the substances that we were targeting, and overall, as I said, the effects were weaker than they had been in previous trials of this program. We did find that the more comprehensive training produced better implementation fidelity, and there was some evidence for better immediate outcomes among the students, but these effects were not maintained, so we did not find evidence for the superiority of the enhanced training in terms of longer-term outcomes. And we were gratified to see that the majority of teachers did sustain program implementation 2 years later. Okay, next slide, please. So, this study, I think, needs to be looked at in the context of ongoing challenges of implementation of prevention programs in schools. And I've been doing this kind of work for 25 years now, and I think this list of challenges doesn't really change much. There are a lot of challenges in the context that make implementation difficult. As we all know, there's a lot of focus now on academic achievement. People feel that they don't have the time to do prevention programs or the resources. There's a lot of efforts to reform schools, some of which have been successful and some haven't. When you scale up these programs in schools, they really have very limited capability to monitor what's going on with implementation, so to either collect data on implementation or on outcomes. in terms of getting the programs in schools in the first place, there's a complex set of stakeholders that make decisions about whether they're going to do a program or not, which makes it difficult to figure out where to even start. And we're in an era where we have limited funding not only for initial implementation of these programs, but certainly for sustained implementation. Okay, so let's go on to the next slide. The second part of my talk is going to focus on an initiative that I'm working with in LA County. So the LA County Department of Public Health is funding this work, and I'd like to acknowledge my colleagues here. So let's go on to the next slide. So what LA County has done is it has received a block grant for substance abuse prevention. And these block grants come from the federal government, the SAMHSA, which is the Substance Abuse and Mental Health Services Administration. So the grants come from the federal government to the state and to the county. This slide describes sort of the overall approach that is being encouraged in these block grants. Communities are being encouraged to focus on those at highest risk, and there is a great deal of emphasis on prevention of underage drinking. There's an encouragement for collaboration across community systems. Local communities are being encouraged to implement strategies that are comprehensive, and they're being encouraged to use a planning process where the strategies they select are data-driven and outcomes-focused. Okay, next slide, please. So this particular initiative came out of the block grant funding. The county released a request for proposals in the year 2010, and the next year they funded 34 organizations to implement 43 different projects, and these were across the county in the county's so-called SPAs, or service planning areas. The projects were either environmental focused or what they call comprehensive, and all of the projects were funded by a contract, and the amount of money that these individual organizations got ranged between $200,000 and $300,000 per year. Okay, so let's go on to the next slide. So the framework, so this shows you the service planning areas in the county, and probably most of you are familiar with these. In any case, these organizations were funded. There was at least several organizations in each of these service planning areas that received these funds. Okay, so let's go on to the next slide. So the framework that underlies this work comes from the federal government. This is called the Strategic Prevention Framework. You know, this is pretty much describes, I think, the thinking about effective community-based prevention that's, you know, guided our work for years. And the idea is that we need to assess needs before we go in and do programming. We need to build the capacity of those who are doing the programming. They should come up with a strategic plan, implement it, and evaluate it. And in this case, there are also principles. Every bit of the work that these communities is doing should be guided by trying to sustain the work, and it should be done with cultural competence. Okay, so let's go on to the next slide. So our particular contract is a contract to evaluate the implementation of this prevention framework, the implementation of these contracts to do evidence-based prevention for substance abuse. And I'll draw your attention to the boxes that are in red. So let me back up a minute. So the activities, again, are basically planning and implementation. And what these interventions are designed to do is they are designed to decrease access and availability of substances, to change social norms, and to change community conditions that lead to substance use. And then ultimately, they're designed to decrease drinking and illicit drug use and misuse of legal drugs among underage drinkers and young adults. Okay, so let's go on to the next slide. So we have been charged to understand the extent to which and how well provider organizations implement this framework. So that is, how well do they do needs assessment? To what extent do they build their capacity? To what extent do they do a good job with planning? And then secondly, next slide, please. We are charged with evaluating how they do in the implementation process and how well they evaluate their outcomes. So next slide. So since the initiative began in 2011, for a year, the communities focused on comprehensive needs assessment. The county required them to collect a variety of data using a variety of methods that are listed here. And then the county required them to come up with a very extensive program plan where they would outline both their logic model or their theory of change, and they would also outline their strategies, objectives, and outcomes. So for the last several years, they have been in the implementation phase of their strategies. And I should also say the kinds of strategies they're doing really sort of fit into two broad categories. They're doing evidence-based programs that are more focused on individuals. So things like curricula, like the program that I described earlier in the webinar. And then they're also doing, the second type of programming that they're doing is policy and environmental strategies. So not the focus on individuals, but the focus on the local community and changing the conditions around access of alcohol and other substances. Okay, so let's go on to the next slide. This gives you a little bit of an idea of who the organizations are that were funded to do these programs and what, how many years of experience they have in prevention work. Most of them had quite a bit of experience in prevention. Most of them were community-based organizations or community coalitions. There's a handful of organizations that have worked on alcohol and other drug treatment. That's what AOD stands for. And those treatment organizations are considerably less experienced in doing this kind of prevention work. Next slide, please. So we have used a variety of methods to evaluate what these organizations have done so far. We've done surveys and interviews with key staff. The first time we did surveys was right after the planning phase. We finished those interviews in 2013, and we're currently in the field now asking about their implementation process. And we've also done coding of their documents, of their prevention plans, their evaluation reports, and we've done quite a bit of observation of various kinds of meetings, including coalition meetings. Next slide, please. So I'm going to present a little bit of our findings about how the planning and the needs assessment process went. So you can see here that many of them valued the needs assessment process. They learned a lot. They thought it was important. On the other hand, they felt that the funds that were provided for them to do this and the time was inadequate. Not that many felt that the data that they collected captured the problems in their community well. So that was kind of a mixed reaction to the whole experience with needs assessment, which took them a year. Okay, next slide, please. Some of the challenges that they ran into, and this probably is true for community-based efforts in the Los Angeles area overall, they really struggled with how to define their target community. They wanted to make sure they weren't overlapping with other organizations that had been funded, and you know, collecting data was challenging because sometimes the boundaries of the community that they had established didn't overlap with the boundaries of the data that they could collect about those communities. The other thing is that the county, as I said before, required them to use multiple methods of assessment, but it was really challenging for many of these folks to sort of look at the corroboration of these various methods and to understand how to interpret findings where there might be inconsistency. They collected some primary data and they had a hard time sort of figuring out, is that data more important than the secondary data they collected, and so forth. And I guess the biggest challenge was that the pace of the process was slow. It really took them a good year to collect the data and to develop the plans, and I think honestly the county didn't anticipate that. I think the county thought this could be done in probably half that time. Okay, let's go on to the next slide. We asked the provider organizations some questions about their capacity to try to get at that question of is capacity for doing this kind of work getting built? And so this is self-reported confidence and capacity. Yes, many of them were confident that they could do a good job implementing these strategies. And, you know, they felt that they had good competency for, good capacity for relationship building and doing service delivery with cultural competence. But they had less confidence that they were going to do a good job and that they knew how to implement the environmental-focused prevention strategies. So this was new to quite a few of them. Okay, next slide, please. So another thing that I'm interested in is how implementation of evidence-based programs is working and will work in community settings. So for most of these organizations that were funded, the idea of using evidence-based programs and the actual evidence-based programs that they were encouraged to use were all new to them. And so we asked some questions about what did they think about this. And on the one hand, the majority said, well, sure, the program that we've developed is likely to be effective. They also thought it would be difficult to implement. They also, a pretty big proportion, if you look at the item at the bottom, didn't show great confidence in evidence-based programs in the sense that they didn't think that the researchers who developed them always knew what it takes to reduce alcohol and other drugs in their community. So next slide, please. This gives you an overview of the kinds of activities that are being implemented. So as you can see, the majority of the work is focused on reduction of alcohol use and marijuana use. Very little of it is focused on prescription or other drug misuse. Most of these contracts are focusing on the short-term objective of reducing access and availability of alcohol and other drugs to young people. And the majority of the contracts are doing at least some work where they are implementing a curriculum or an individual-focused evidence-based program, and a good half of them are doing policy development, policy work focused on changing the environment. Okay, next slide, please. So this gives you an idea of the kinds of specific strategies that they are implementing. In the environmental area, they're doing responsible beverage education. They're trying to get ordinances passed, such as social host ordinances, where you hold the social hosts liable for problems that may ensue after they serve alcohol. And then I've already made reference to the kinds of comprehensive strategies or individual-focused strategies. Their curricula, their education meetings, and so forth. Okay, so next slide, please. So what have we found overall? We have found that organizations did increase their capacity to do needs assessment and planning, although some of the plans, when we took a look at them, what they were planning to do seemed to come out of nowhere. They were not really data-driven. And we've seen an improvement in the quality of the plans over time. This has been an interesting rollout of evidence-based programming because the organizations that have been funded have had a lot of challenges in understanding what the county wants them to do, what kinds of protocols they want them to follow. Those are some of the findings in terms of planning. In terms of implementation, the overwhelming finding has been that the shift from treatment approaches and prevention that is education-oriented, individual-focused, to environmental strategies and policy work has been really challenging for most of these organizations. I think in part because it was new to them, something that they didn't have that much experience with, and maybe also in part because those kinds of strategies are sort of less manualized and less well articulated than say, a curriculum approach. And as I made reference to earlier, there's been some resistance to the use of evidence-based programs overall in this initiative. Questions like, well, do they really fit in our communities, and are they really better than what we're doing, and why do we have to do these programs that were tested in different kinds of communities, and so on. So next slide. So just so you know where we're going in this project, our next step is to take a look at what kind of impact these prevention programs are having on substance use among youth and adults overall. So we're getting ready to do a school-based survey in the next school year of youth who are high school aged. So next slide. So I guess in conclusion, what I would say across these two projects and what we talk about in this paper that I made reference to earlier, I think we have a ways to go in terms of research on dissemination and implementation. I think we continue to need some innovations in design and methodology and theory. I think one thing that's really clear from the work that I've done and many around the country have done, we need infrastructure. We need funds, we need resources that will support not only the evidence-based interventions, but also research on the implementation of them. We're not going to advance the field until we have stronger infrastructure, in my opinion. There's a need for more synthesis of findings across the work that we're doing, and a better exchange of knowledge that comes from both research and practice. So thank you very much.
Great. Thanks so much, Dr. Rohrbach. And we wanted to open it up for questions, but before we did that, I just want to alert people that we will be doing a short evaluation poll, and so if you're on the webinar, please look out for those questions, and you'll see them flash on your screen before we conclude the webinar. So I think there's a manageable number of us on the call that we can open it up for questions, but if anybody also wants to put a question into the chat function, we will certainly see that question. Also, if you put your question there, we don't have time to get to it. I'm sure we can figure out a way of getting a response to you after the webinar. So I just wanted to open it up and see if anyone would like to jump in with a question or comment or thought.
Yeah, and everybody is unmuted, so
you should be able to speak. If not, let us know. So maybe I'll jump in with a question while others are perhaps formatting theirs. I guess one question, Dr. Rohrbach, just in terms of the first presentation or the first study that you were speaking about, was wondering if you had thoughts about what happened with respect to why the diminished effect, and if you thought it had to do with the extent to which certain key mechanisms for the intervention perhaps weren't done as much in the real world setting as they were in the original program, where you had kind of more control over or had particular people responsible for the intervention.
Yeah, I mean, I think that's a reasonable explanation for what happened. You know, even though we measured fidelity and we felt pretty confident about our measures of fidelity, we had used them in previous trials. You know, even when we looked at the immediate outcomes, we didn't quite see the pattern of immediate outcomes that we had seen in other trials. So maybe there was something missing there, and maybe the implementation just wasn't as strong as it was when we had done it ourselves in previous trials. And, you know, we were only able to, because these sites that we studied were all over the country, we were only able to go in once and take a look at what was going on. So it could be that you know, that our glimpse of the implementation process didn't really fully show us what was going on.
So I had one other question just to throw out, which is, and others might have thoughts about this as well, but if you had thoughts after the experience with the challenge of the data collection, I was wondering if you came away with any ideas of ways that might work to set up data collection that would be more manageable for kind of real-time tracking or for tracking what was happening, since clearly measurement was a burden. And here I'm still thinking about the first study that you presented.
Okay. Yeah, so I think what people are encouraging nationwide, I just actually returned from the conference of the Society for Prevention Research, and you know, I think that probably the most realistic thing is that efforts like this could tap into ongoing surveillance systems, and there are some that are still active in schools where either the state or the county has been measuring substance use through either the Youth Risk Behavior Survey or another survey, and so, you know, using more like a time series kind of design, and maybe if there's a way to subset the data among the schools or from the schools where the program implementation is really going on. So I think tapping into existing kinds of systems is probably more realistic than thinking that we would have the funds and resources to evaluate ongoing implementation of programs of this type.
And there's a thought about the time series, that in part that might show you where, instead of kind of a pre-post, you would have a sense of where people are in a learning curve, or whether things took a while to take off when they were beginning to take off, but the data didn't quite capture that for you, in a sense.
Right, right.
Great. switch it. We're actually starting the poll now, so folks can you'll see that pop up on your screen. So it'd be great if you can go ahead and fill that out while we're finishing up with some last comments. Is there anything anyone on the call have anything to comment on, either with respect to the presentation or any of the discussion so far?
Hi, yes, I have a question. Can you hear me okay?
Yes.
Yes.
Hi, thank you for the presentation, Dr. Rohrbach. I have a question for you. You spoke about factors that influence adoption and use of evidence-based programs. And so I do clearly understand that you need to find a champion within the school to partner with. But I do have a question for you regarding the decision-making stakeholders. You spoke about it being a complex mechanism. So do you have any basic blueprint of where you should start in order to begin the conversation of introducing a program into the school districts?
Yeah, that's a great question. So from my experience and others around the country, generally, you know, most school systems are still fairly hierarchical, and so a lot of times you need to start with the highest level decision makers to make sure that something will get done or implemented on the ground in the actual classroom. Ideally, a school district has some kind of a committee or decision-making body that is comprised of those higher-level administrators as well as representatives of the schools, like teachers and principals. So where you have that kind of mix of stakeholders, that's ideal. But if you don't have that, then what we have found is that we usually start at the top and talk to whoever we need to, and sometimes you need to go before even the school board and present, you know, the value of the program. And then once you get approval at that level, then you can start working with the folks on the front lines and get a committee of them together and get their buy-in. So sometimes that champion in a school, actually sometimes it might be a teacher or a principal who's been involved with the decision-making from the start. Sometimes it's a district official who happens to know about the particular program or intervention and has heard about it at meetings and says, oh, you know, I've heard this is great, we should really do this here. And then that person works to get it approved at all levels. So, you know, I think it's complex just because there's so many different stakeholders at different levels. Sure. And then in some districts also you've got strong parent involvement, and sometimes parents feel strongly about a program like a substance abuse prevention program. Sometimes they don't, so it's important to bring everybody in, and if you've got a structure already in the district, that's great.
Okay, thank you. I have another question, if it's okay with the moderator.
Yeah, just quick, if you're on your WebEx, we have started the poll, so if you can just take 2 minutes, not even 2 minutes, just to fill out the poll, it would be great, so that can just help us.
Sure.
Yeah, go ahead with your last question, and then just want to make sure people notice that in the webinar announcement, we have an announcement about the next date for the webinar. So just wanted to let you know it's coming up later this summer. But please go ahead with your the last question. Thanks.
Thank you. Real quick, you spoke about substance abuse programs having to be evidence-based. Do you know if that is the standard across the board for other
topics within school-based programming?
Yes.
Well, that's an interesting question too. I think that that substance abuse is sort of further along than other kinds of topics in terms of prevention programming. That is, there's been, you know, a greater history of research, and there's been more systematic efforts to develop registries and lists and so forth of evidence-based programs. But there are also now standards for programs that focus on risky sexual behavior reduction. So there's a whole group of programs that are being implemented in schools that are funded by the Federal Office of Adolescent Health. And so those programs, in order to get funded, they have to select from a group of programs that have been identified as evidence-based. So in that subject area, there are standards, there are programs. I'd say in the area of programming that focuses on promotion of exercise and dietary habits, I think researchers have a good idea of what's evidence-based and what's not, but it hasn't quite been packaged as standards for schools as yet. But I think that's coming. I think we'll see that in another 4 or 5 years.
Thank you.
Thank you. Thanks so much, Dr. Rohrbach, and thanks for the questions, and thanks everybody for participating.